is BI-RADS in mammography. Can we have the video, please?
Dr. Suman? वहां से अनशेयर करना आशीष मैं कोर्स में अभी बन जाऊंगा आ जाएगा
Good morning, everyone. First of all, I would like to thank the organizers, especially Dr. Varsha, of this Breast Update 2022 for giving me the opportunity to be a part of this conference. I will be speaking on BI-RADS in mammography current status. As we all know, breast cancer is the most common cancer among women, and every year 1.6 million cases are reported of breast cancer. 450,000 deaths are because of breast cancer, out of which 70% deaths are those which occur in the poor and moderate income countries. So it is very important for all of us to detect breast cancer early because that is the best protection available. Strength, courage, and hope are what we are looking for in future. This you all know is Angelina Jolie, who got her preventive double mastectomy done, and she says that I do not feel any less of a woman. I feel empowered that I made a strong choice and in no way diminishes my femininity. So what does BI-RADS lexicon means? BI-RADS is basically breast imaging reporting and data system, which is a standardized system of reporting any breast pathology, and it is used in mammography, ultrasound, and MRI. Published by American College of Radiology, that is ACR, initial edition of BI-RADS was created in 1993. The second, third, and fourth editions were released in 1995, 1998, and 2003. After a gap of almost 10 years, the fifth edition of BI-RADS was released in 2013 with many numerous changes, which was towards a goal of giving a standardized reporting in today's date. So in BI-RADS Lexicon 2013 or the fifth edition, multiple new descriptors or the words have been used to recognize the increasing risk of breast malignancy, and historic terms which were not used or underutilized have been removed from the BI-RADS. Moreover, newer techniques like shear wave elastography has been incorporated in the BI-RADS ultrasound lexicon. Today, we will be discussing only BI-RADS 5th edition lexicon in film mammography. So how do we go about in any breast mammography? First of all, we look at the indication. We describe the breast composition, that is A, B, C, D. Important findings like mass, asymmetry, architectural distortion, calcification, or associated features. Then if the prior mammograms are there, we compare with that and we give a final assessment category, give the management recommendations, and further refer to the clinician for any other findings which are there in the mammography. So this is how we give the different categories in any BI-RADS, which you all must be getting in your reports, either BI-RADS category 0, 1, 2, 3, 4, and 5. When we say BI-RADS 0 on any film mammography, we are trying to say that we need additional imaging for or prior examinations, as we are not able to come to a conclusive diagnosis on this mammogram. When we say BI-RADS 1 or 2, that is totally benign mammography with benign findings. When we say 3, we are trying to say that it is probably benign and it requires a short interval follow-up, 6 months or so. When we say BI-RADS 4 and 5 category, that is suspicious or highly suggestive of malignancy, and a histopathological correlation is needed. BI-RADS6 is basically histologically proven malignancy or a known biopsy proven malignancy which is there, and a surgical excision is required. So this is BI-RADS 5th edition on film mammography here and on ultrasound, which is there and which is to be followed by today's radiologists, and so that it communicates well with the clinicians and gives a present day standardized reporting on film mammography. In today's scenario, the breast composition earlier was ACR category 1, 2, 3, 4, which is now removed, and it is now A, B, C, D, either entirely fatty or scattered areas of fibrogranular density. Heterogeneously dense is category C, or D, that is extremely dense and it lowers the sensitivity. The mass, asymmetry, architectural distortion, morphology of the calcification, and associated features we will just try to do in our subsequent slides. So breast composition, as I said in BI-RADS 2003, in all our prior reports, we used to write ACR category 1, 2, 3, 4, which we were trying to say how much is the percentage of the fibroglandular tissue which is present. If we used to write ACR category 1, that was less than 25% of the fibroglandular tissue, and category 4 was more than 75%, that is extremely dense breast. But 2013 BI-RADS says that you should not give any percentages, because what is more important is that how much is the mass getting obscured by the fibroglandular tissue than giving these percentages. So as we are seeing here, this is a slide to show that subjective assessment of breast density, how it is done. So A, B, C, D is a fibroglandular tissue. We are trying to say this is entirely fatty, scattered areas of the fibroglandular density, and this is heterogeneously dense, and this is extremely dense. So no more percentages now, and this is how we are supposed to write the subjective breast density in the first line of our report. So if we see these two mammograms, these are of different patients, and according to the prior BI-RADS, we would have given this category 2 and category 3, depending on the percentage, less than 50%, more than 50% of the fibroglandular tissue. But in today's 5th edition lexicon BI-RADS, we will call it composition C both as heterogeneously dense or heterogeneously fibroglandular tissue which is present, because there is more of a fibroglandular tissue in the upper part of this breast which can very well obscure a mass. So that is why we are calling it composition C of the breast density. Now coming to mass, a mass is a space occupying 3D lesion which is seen in two different projections. We take craniocaudal and the oblique views. If a potential mass is seen in only one projection, it should be called asymmetry until its three-dimensionality is confirmed. So this is a difference between mass and asymmetry, which we write in our reports in the film mammography. So if we see any mass, we are further supposed to define the shape, the margins, and the density. Shape is either oval, round, or irregular. Oval includes few lobulations. Margins can be circumscribed, obscured, microlobulated, indistinct, or spiculated. Density high, low, equal, or lower fat containing. So 4th edition, these were the terms used. In the 5th edition, these changes are that we have reordered the oval and the round shape, and we have omitted the lobular word. So you will not find lobular word anymore in our film mammography reports. It will be oval, round, or irregular. Irregular are more prone for the malignancy. Margins, we have reordered the microlobulated and obscured, and in density, we have omitted the radiolucent, and we say high, equal, or low density of fat containing. This is a fat containing lesion with a popcorn-like calcification, which is very diagnostic of a hematoma or a fibroadenolipoma, and these are the fat containing lesions which are typically benign. These are the mass shape which I was talking about: round, oval, and irregular. Oval can include few lobulations, and irregular masses are the masses which are more higher probability of malignancy is there. We talk about margins. The margins can be circumscribed or obscured, microlobulated, indistinct, or spiculated. So these three margins are more prone or suspicious for malignancy, and these are margins which tell us that the lesion can be benign. We talk about density. It can be low, equal, and high, and we compare the densities with the fibroglandular tissue density. So usually the higher density means the lesion is more suspicious for malignancy. These are multiple round circumcised low density masses which we are seeing on this mammogram, and these are the result of lipofilling, which is a transplantation of body fat to the breast. And you guys are the best judges for seeing such mammograms. If we see a hyperdense mass like this with spiculated margins and thickened skin, we all know that this is a BI-RADS 5 and a malignant lesion, and this on biopsy proved to be an invasive ductal carcinoma. When we talk about calcifications, the calcifications can be benign or malignant. We are supposed to write whether the calcifications are diffuse or linear or at focal one place. So distribution is also supposed to be written. And there is a concern that we are not using the words scattered or clustered now. We are using the word diffuse, regional, grouped, linear in the report of calcifications. So in the present day BI-RADS 5th edition, they have categorized the rim calcifications, these punctate as well as these axial calcification into one category. The round calcifications like this here, round and punctate again into one category. So lucent centered and axial are into one category, and punctate and round into round calcification, and these calcifications are usually benign. If we see the calcification like this on the zoom projection images, these are coarse heterogeneous or amorphous or fine pleomorphic, or this fine linear calcification or linear branching. These are suspicious calcification for any malignancy. So I'm just trying to give you all a brief overview of how the BI-RADS work and what a radiologist is trying to tell you, the surgeons and the clinicians, that what this film mammogram is trying to signify. The architectural distortion is there. So now we use the words like asymmetry, global asymmetry, focal asymmetry, and developing asymmetry is a new terminology which has been incorporated in this new BI-RADS. Intramammary lymph node, skin lesions, or solitary duct, if they are there, these are the separate findings which are supposed to be mentioned. No more term like asymmetric tubular structure is to be reported or used in the film mammography. So developing asymmetry, which is a new terminology in 5th edition BI-RADS, is that here we are seeing these oblique mammograms which are there in the annual screening program of the same patient. And we are seeing that there was this posterior central left breast, there is this asymmetry which was there, which kept on increasing in the subsequent annual screening mammograms. So this is a developing asymmetry, and this is consistent and it has to be reported because this can turn into a malignancy. So this is important, and developing asymmetry is a term which is incorporated in new BI-RADS. Architectural distortion, if it's there, which actually means that the normal architecture of the breast is distorted and there is no definite mass. It can be either thin straight lines or focal retraction or distortion or straightening at the edges of the parenchyma. So usually this kind of architectural distortion is basically either a scar tissue or a malignancy. So how do we differentiate between that? We take out the zoom images, and usually the masses which are causing or with the architectural distortion are the masses which are more likelihood of malignancy than the masses which do not have that. So here we are seeing that there is distortion of the normal architecture. Here on this oblique view, we got the zoomed images, and later on we tried to biopsy this, and this turned out to be a scar tissue. So architectural distortion usually signifies either a scar tissue or a malignancy, and we certain times have to biopsy that to come to a conclusion. So associated skin findings which are there, skin retraction, nipple retraction, skin thickening, axillary lymph nodes, calcifications, all these lesions are to be reported in the new BI-RADS 5th edition. So just to show you in a case where there is this global asymmetry, you can very well see that in compared to this breast, there is kind of more fibroglandular tissue in this breast. So there is a global asymmetry. And this is not a normal variant. Why I'm saying that? Because I can see this skin thickenings, thickened septa. There is a little, subtle nipple retraction. Here we are seeing the nipple. Here it's not well seen. So this was kind of suspicious. And further ultrasound detected that there were multiple small masses here, which turned out to be adenocarcinoma. And this is a PET image to show that this was a basically diffuse infiltrating carcinoma. So a simple thing like global asymmetry with these associated findings became so important to diagnose this infiltrating carcinoma. So whenever we are doing the BI-RADS 3 category, that is short-term follow-ups, we have to see either we downgrade the BI-RADS category subsequently or upgrade it. So this was a patient who had undergone this subsequent mammogram annually, and earlier this was given BI-RADS category 3, and on the follow-ups it remained same. So this was changed to BI-RADS category 2 later, that this was absolutely a benign lesion. In this mammogram, we are seeing this amorphous calcification. This was given a BI-RADS 3 for a short-term follow-up. And after a 1-year follow-up, we saw the calcifications have increased. They have become 4 to 5. So this now was further categorized to BI-RADS 4, and it turned out to be a DCIS or an invasive carcinoma. This was a patient who had come for a painful mobile lump into the right breast. No history of any prior pathology was present. No previous exams were available. On mammogram, we are seeing that this was composition B. Scattered areas of fibroglandular density was there. And laterally, we are seeing that where the lump was palpable, there is a mass, oval mass, and the margins are partially circumcised or partially obscured. And the mass was equally dense as compared to the fibroglandular tissue. And we said that this is 9 o'clock position, middle third of the breast. So we described the mass well in terms of density, the shape, the margins, and later on, the size was also given. On the concurrent ultrasound, we found that this mass was basically an anechoic cyst, which was parallelly oriented, circumscribed well, and with posterior enhancement. And there were few more cysts which were present. So combining both mammogram, the ultrasound and mammogram, this came to be a BI-RADS 2 or a benign finding. Only on mammogram, we would have probably given with a palpable lump and partially indistinct margins, we would have called it BI-RADS category 3. But when we did the concurrent ultrasound, this was just a cyst, and BI-RADS 2 was given combined. So, and since this cyst was palpable, after the informed consent, uncomplicated puncture was done for the suction of the cyst. And this was no indication for follow-ups. These are few mammograms which are there of the breast implants and all, which you guys do day in and day out. So this was just to show that how extracapsular rupture will look like on this patient mammogram with silicone implants. And these are free silicone which migrates outside the fibrous capsule to the breast parenchyma. This was a mammogram to show that this was a right retropectoral saline breast implant and retrograndular saline breast implant which was there. And in this breast, in this mammogram, the silicone shell has collapsed, wrinkled and folded on itself. So this is how the different implants are there. If the normal implants are there, we call it BI-RADS category 2, and this is very well considered as a benign finding in the film mammogram. So what Charlotte Ross said, that mammograms are really sort of gift. You can either catch something early or count your lucky stars because nothing was discovered. So either way, you are ahead of the game. So mammograms are a gift to all women. And thank you so much for this patient listening.
Dr. Suman Singhal is Director Cardiac Imaging and Head of Department of Radiology and Imaging at Fortis Hospital, Jaipur. Due to certain exigency, she could not attend this meeting physically, but she was kind enough to send her video presentation at last minute. And we are thankful to Dr. Suman for such an excellent presentation. Moving on to our next speaker. Our next speaker is Dr. Uttam Soni. Dr. Uttam Soni is an oncoplastic breast surgeon at Sita Devi Hospital, Jaipur, a graduate from SMS Medical College. He did his basic and higher surgical training from Royal College of Surgeons of Edinburgh and King's College, London. He is CEO of Asian Society of Mastology and founder chair of Breast Global. Now I'll invite Dr. Uttam Soni, and he would be speaking on benign breast disorders.
So, good morning, everyone. I would like to thank all of you for giving me this podium to share my experiences. Now, this incident actually goes 20 days back when Goel sir called me up and he said, we are having a close CME. Surgery to hum log kar rahe hain sab, kuch naya ho to batao. I said, so there are two things that we are working on. One, Manish should be sharing with you. We are working on SBRT, and which has got wonderful, gratifying results. Stage 4 disease with radiotherapy, we are treating it. The second thing is, I said, iske alawa naya kuch nahi hai sir. Fir jo galtiyan kari hai, wo discuss kar sakte hain. I said, okay, come out. And then 3 days back, Dr. Varsha called me up and she said that, हमने तो आपका नाम benign breast disease में डाल दिया है. I said, okay. We'll discuss both of them, but I think more important is my mistakes that I would like to share. I think all of us make it day in and day out. This topic or this talk should have been in the last of this, but fair enough, we can always discuss it at the beginning. So this is my 5 mistakes that became lessons in my life. I'm Uttam Soni. Now this is very difficult because these are going to be true confessions. So, whenever as a consultant you make mistakes, it is very difficult to accept them in open. Aisa kiya hai, galat kiya hai, nahi. But these are true confessions that I'm going to make out here. And I think once you hear them and you go on yourself, you see that all of us do it. Important thing is to stop and learn from them. Kabhi aisa bhi tha main. This is 10 years back when I was working in London. So more important is only grave mistakes become lessons. Choti mistakes karke, we don't learn from them. We only learn when they make some impact on your practice or on your psychological status. So they have to be big. And what is important is what is your threshold of considering your mistake as grave. Now, somebody can have a low threshold. A very small mistake can be a lesson for him. And somebody can have big thresholds, high thresholds. बड़ा करके भी कुछ पता नहीं पड़ेगा. They think, हो गया, that's it. Again, this is from my college. Thankfully, I have a low threshold. So I just take them very seriously whenever I just talk to myself about the problems or the mistakes that I've done. Most important thing that I've learned over these 47 years. मात पिता गुरु प्रभु के बानी बिनय विचार करिए सुख जानी. whatever your father, mother, teacher, God, they say to you, just do that. They're never going to be wrong. This is the most important thing that I've learned over years. My parents, and we start with the mistakes that we do it. Can you do it for me? We can always ask our juniors or colleagues, "Yaar, tu kariyega kya ye kaam? Can you do it for me?" There's nothing wrong in that. But important thing is to recheck on it. Jaisa aap chahte the, the way you want it. Has it been done the way? How it came to my mind was initial years of my training when I was working in hand surgery. We had a surgery on right hand. And I asked my senior house officer, go and mark it. Mark kariyo. And this fellow went and marked the left side. Came out, boss, done. My consultant asked, everything done? I said, yes, boss, done, all done. Fortunately, the nursing staff was smart enough and they have, these checkpoints. So the nursing in charge from the ward, she called me up and said, Uttam, this patient probably is going to have a surgery on right side. And she has got a mark on left side. I'm sure it would not have been done, but this happens. We hear about these things very frequently in India. And I said, oh yes, I should have seen it. But I asked John to do it. And she said, it's not John's responsibility. You are the registrar, it's your responsibility. I said, yes, it's my responsibility. I learned that day that either I'm going to mark it myself or whenever I ask my juniors or colleagues to do something, I need to recheck it. This is a picture of MAMCare launching. MAMCare is the first structured breast cancer screening program here in Jaipur. We launched it in 2012. It's working very nicely. We do approximately 800 mammograms a year on this. Learn to say, I don't know. So I'm trained, I'm well read, but I'm not bound to know everything. We should have that courage and honesty to speak on and say, okay, fair enough. We can discuss it. Let me go and find it out. Or let me discuss with my colleague. I don't know this. We always have to be that open and that upfront. If it's not in my forte, if I'm not experienced, if I'm not trained for that, I should never try my hands on it. I should always say, nahi aata bhai. Dusre se baat kare. This is Padma Shri Dr. Ashok Mehta. He is delivering the annual MAMCare rotation, 2013. Follow the protocols and SOPs very religiously. One of our habits is to cut corners. We should never do that. Small story. 2014-15, young lady, 30 years old, known relative, Sony, came from village, referred to me. Husband is well read. Wife is well read. They're doing good business. They're read in Singapore. They come to me with a breast lump. On examination, mobile. Ultrasound, BioReds 2. Examination, E2. What is this? It doesn't look like cancer to me. This is what I said. Now, the protocol says, before defining a lump, do a proper triple assessment. Before you give your verdict, you should have everything objective, black and white on your paper. This is what the rule is. I said, it doesn't look like cancer. The doctor said, क्या करना है? मुझे निकाल देंगे? 2014-15, young, on my own practice, 30-40 हजार रुपए आ रहे हैं, किसको बुरे लग रहे हैं? I said, doctor साहब कर दो. And because we were doing these procedures under local anesthesia, कब करेंगे? अभी करेंगे. 1:30 or 1:30 or 2 o'clock in the afternoon, lunchtime, जाने से पहले पैसे कमा लें. The thought process is this. I said, doctor साहब कर दो. He paid upfront. Patient went in, local lagaya, incision, lump out, and patient home. And diagnosis came as invasive duct carcinoma. The story doesn't stop here. This is not the learning. The learning is after this. Husband calls me up, doctor, uski report aa gayi. I said, yes. You need to come in and we need to talk. And he came in 4 or 5 hours. Well-read man, educated. So he understood that there is something which is very heavy, the gravity of that situation. Dr. Saab, क्या unfortunately इनको कैंसर आया. आपने तो कहा था ऐसा हो ही नहीं सकता. मैंने ऐसे नहीं कहा था कि ऐसा हो नहीं सकता. मैंने कहा it looks like it's benign. So he is picking up my words and I'm eating my words. डॉक्टर साहब उस दिन आपके थिएटर के अंदर 3-4 सर्जरीज हुई थी, कहीं ऐसा तो नहीं है कि ये मिक्स हो गया हो किसी और के साथ? नहीं. We label them straightforward. I was very confident about that we label them very straightforward. So this is not the way it has been done. This is your wife's specimen only. He went off. 7-8 days down the line, the pathologist called me up. Everybody knows him. Manish is a wonderful oncopathologist. He calls me up. I said, boss, you got a patient. Huh? You reported it? Boss, beware of this patient. Why? Because he came to me and he said, the DNA of the tissue on the block is of a male. Do you understand? To the extent the patient is going on. He said the DNA of the tissue on the block is a male patient. This is not female. Now this is just 10-12 days down the line that we have operated on this patient. I said, do you have the specimen? He said, yes, I have the specimen. I said, okay, fair enough. Next time he comes to you, you send it to me. And he called me and said, Dr. Saab, there is something which is very fishy going on. I said, what? Look, the DNA is of a male patient. I said, look, it doesn't happen like this. There must have been some error. This is what I'm telling you. There must have been some error. My wife cannot have cancer. I say, okay. So we have the whole tissue left with us, the specimen. You can take it, get it done, and then come back to us. Fortunately, the specimen was hers. And he had all the results that we said. They were all validated. But these 7 days, 8 days, it gave me hell of, stress on my head. The patient also was on an aggressive side. I could not treat this patient after this because he went somewhere else. He lost faith in me. Had I been very polite and did my own triple assessment properly, this position would not have come in. He came in, I should not have given my word date. I said, look, we need to do a mammogram, an ultrasound, a tissue biopsy, and then only I would be able to make a statement to you. So very important, do not cut the protocols, do not cut the corners, and follow your protocols very religiously. The protocols are meant to be followed. They are made so that we can make our life easy. My mother and father, look how happy they are. This is the first time they went to me in England, and we are at the Blue Water. So do not enter the room if you don't know how to come out. Sometimes we think of that, surgery kari nahi yaar. We've learned this. We can do this and we'll come out. No, if you have not done it, don't go in. I'm not going to tell the incidents for this. But this is something which I've learned. If I'm not versed with a procedure, I would not try my hands on it. It will put you in a shithole. Very difficult for you to come out. 25 years celebration, silver jubilee of our batch, and Dr. Kabra and Dr. JC sir. Look how happy they are to see us. Do not help patients outside your legalities. Very important. The moment you try doing that, you are in that chakravyuh. And then you can never be on the driver's seat. They will drag you wherever they want. Small incident, but I've learned a lot from it. Patient came to me and he said, Dr. Saab, aapse bahut impress ho gaya main. And I was like on the top of 7वें आसमान पे. Operate आपसे कराना डॉक्टर साहब वाइफ को. जयपुर में सब जगह पे दिखाया, लेकिन आपसे बढ़ के कोई नहीं मिला मुझे. Fair enough, I'll do it. डॉक्टर साहब मेरी वाइफ का इंश्योरेंस 2 महीने में खत्म होने वाला है, आई गॉट 4 लाख रुपीज इन बोर्ड, कैन यू प्लीज डू दैट? वो 4 लाख निकाल लो ना डॉक्टर साहब। फिर अगले साल अपन, क्योंकि लंबा चलने वाला है, 1 साल, शी वाज HER2 पॉजिटिव, डॉक्टर साहब 1 साल चलने वाला है ट्रीटमेंट, वो पैसा अपन काम में ले सकते हैं। आई डोंट नो व्हाट गॉट मी इनटू दिस, आई नेवर गेट इनटू दिस, बट वो हो गया एक इंसिडेंस एंड आई सेड ओके, बिकॉज वी आर अ प्राइवेट हॉस्पिटल, वी कैन मैनिपुलेट फ्यू थिंग्स, लेट्स डू इट फॉर द पेशेंट। डॉक्टर साहब पिछले 20 साल से भर रहे हैं हम लोग इंश्योरेंस का क्लेम, आज तक निकाला नहीं है, ये तो 4 लाख रुपए पहले निकाल लेते हैं। So we did that. And you know, he didn't pay a penny after that. अपनी जेब से 7-8 लाख और लग गए और कुछ बोल भी नहीं पा रहे हैं. Not able to say anything. He will always come with that paper on the side. At some stage, we were just praying. The whole staff, the whole entire hospital was praying. इसका ट्रीटमेंट खत्म हो रही है, बाहर जाए. Small incidents, you're trying to help this patient, they will backstab you. They will always put you in problems. So with your legalities, do whatever you can to help them. Don't do anything outside legalities. Don't do that. This is 25 years of my school. Wonderful. I'm from MPS Jaipur. So this is a wonderful camaraderie that we share. Only health is your real wealth. So we work day in and day out to make a fortune in terms of money, car, bank balance, land bank. But we forget that the biggest gift to us is human body. 2015, I had an acute renal failure with a single dose of diclofenac, and I realized that I'm not going to work for my parents, my family, my kids. I'm just going to work for this body that God has given to me. To take care of yourself, keep yourself healthy. Fit bol nahi sakta main, but healthy. So this is MAM Care. This is MAM Care run that we organize every year. For last 2 years, we've not been able to do it. But this is a wonderful awareness program that we do in Jaipur. Approximately 5,000 people attended. And the environment is very lively, very warm environment. That is there. The asset that you earn over your life is family. Nothing stays with you. It's just the family that stays with you. Second thing after your own body and health. My father and mother's 50th marriage anniversary, and look how happy everybody is there. My school, 12th class, biology section. And now we come to the topic that Dr. Varsha told me to discuss with you. I'm just going to discuss in brief about benign breast diseases. We all see them day in and day out. I'm just going to share what we need to do, what I have learned that we can do and we should not do with these things. Benign breast diseases, do's and don'ts. Nostalgia. 2 minutes. 2 minutes. So nostalgia, a very common problem coming to your clinics. 60% of the patients that comes to a breast clinic are with nostalgia. Do's, we do a very careful examination. We need to differentiate between true breast pain and pain coming from the chest wall. Again, out of this 60% patient, 90% comes from the chest wall. They are costochondritis. So careful examination will rule that out. We need to have a good history, whether it's cyclic or non-cyclic. I've told that to rule out costochondritis. Counseling at length. Once you are happy with yourself, you tell this patient nothing to worry. The pain can stay. The pain can come back. They are not worried about pain in the head, hands, or legs. They're worried about pain in the breast. So we have to explain them. These patients can take 2-3 hours of your counseling, but counsel them at length. Simple oral or topical NSAIDs. That's it. Don't give them any hormones. No danazol, no tamoxifen, nothing else. Ibuprofen plus paracetamol, warm compresses, and local diclofenac. That's it. They settle down. Avoid unnecessary interventions. Some people, they do come in and say, Doctor Saab ne surgery batai hai. No surgery for these patients. Breast lump, do a proper triple assessment. We need to have USG guided true cut biopsy. FNACs won't do it. Just make a habit of getting a true cut biopsy for every breast lump. Surgery, skin incision should be aesthetically acceptable. You being plastic surgeons, I don't need to teach you about that. And no surgery without core biopsy. Need to have core biopsies there. Breast cyst, don't try to do surgery. Do a good ultrasound. Try to aspirate them under ultrasound guidance. And look for, I'll just go back. Look for solid components or complexes. These are the things that we should pay attention to them. Nipple inversion, good triple assessment. Early surgery is always warranted in these patients if it's benign. Counsel for paresthesias and possibility of failure to breastfeed. Very important. They save you from a lot of problems in future. And avoid incision on the nipple. Try to give a periareolar incision. Nipple discharge, do fluid cytology, microdocectomy in selective cases. Don't do surgery for all of them. And don't use antibiotics for most of these patients. They can be because of ductectasia. Patient may complain, pus aa raha hai, but it's not pus. It's just that greenish discharge coming from ectatic ducts. Breast abscess, I normally avoid incision and drainages. Multiple USG guided aspirations and washouts with local anesthesia. They clear most of them. Mastitis, very important. Do a careful evaluation to differentiate between bacterial, atypical granulomatous mastitis or tubercular mastitis, because the treatment will change entirely. And careful use of steroids in AGM. Continuous USG follow-up. Asymmetry. Fibrocystic disease, surgery, no. It's a normal condition. Never operate on these patients. They will come to you forever with problems. Aapne operate kiya, theek nahi hua. And never biopsy a breast lump in kids. It can be a developing breast bud. So avoid that. ASOMACON 2022, 14th to 16th October in Jaipur this year. This is Asian Society of Mastology. And we have this run on 16th of October. So get your running gear ready. Again, some photographs. The spirit. Thank you.
We'll take questions later on. Thanks, Dr. Uttam, for an interesting presentation. It was almost like we were watching a sequel to Chetan Bhagat's 3 Mistakes of My Life. Our next speaker is Dr. Manish Chaumal. Dr. Manish Chaumal is Head Radiation Oncology. He's Medical Director at HCG Cancer Center, Jaipur. And he's a member of ESMO, AROI and ISNO. He would be speaking on SBRT, Changing Viewpoint in Oligometastatic Breast Cancer. Dr. Manish Chaumal.
Very good morning to everyone. And first of all, I thank the Plastic Surgery Association for giving this opportunity to talk about something which you might feel very different from what you are going to learn today. I thank Dr. Uttam, partner in my crime or our crime, that to dare thinking of curing some of the so-called metastatic breast patients. So before I start the talk, I'll just ask one question to the entire forum. आप में से कितने लोग एक्टिवली सीए ब्रेस्ट के मैनेजमेंट में इन्वॉल्व रहते हैं? You can please just raise your hands. कोई भी नहीं? I have been told that reconstruction, post MRM, BCS में मतलब इन्वॉल्वमेंट होता है. डॉक्टर प्रदीप से पूछा था मैंने. Okay, right. Have you ever thought of having a surgery for a metastatic patient, metastatic CA breast patient? कभी सोचा कि हो सकती है, या नहीं सोचा तो कभी सोचा कि कर सकते हैं? नहीं. तो so then it's good, because then I will be probably able to change the viewpoint of most of the audience here, because nobody is receptive to this idea of treating locally for a metastatic breast. So first we'll learn about the concept of oligometastasis. So it happened way back in 1995 that this term came into the picture. So before that, पेशेंट या तो मेटास्टेटिक है या तो नॉन मेटास्टेटिक है, मतलब एक रिजिड वॉल इज देयर कि या तो क्योर ही होगा या तो क्योर नहीं होगा, एंड देयर इज नो इन बिटवीन ओवरलैप एरिया. बट विद दिस टर्म ऑफ ओलिगोमेटास्टेसिस इन 1995 सम ऑफ द रिसर्चर्स फाउंड दैट लोकल से डिसेमिनेशन होने के बीच में एक ट्रांजिएंट स्टेज है जिसको आइडेंटिफाई अगर प्रॉपर करें तो दीज पेशेंट डिजर्व अग्रेसिव ट्रीटमेंट, including the local therapies. Otherwise, what we all people who deal with local kind of treatment, like surgeons or like us radiation oncologists, probably find that we don't have any place for their treatment, and these patients are labeled to be doomed and just to receive palliative treatment only. So what they told, there is a spectrum theory which is described as that there exists an intermediate state between local and widespread disease, and they coined it oligometastasis. So this was in 1995. The concept, this was presented in last San Antonio Breast Conference 2021, that local is a disease where we feel that the cure is there and local treatment has some major role into that. But once it comes to oligometastasis, cure still can be possible for few carefully selected patients. And then lastly, the systemic disease, or the so-called what we over a time learned metastatic disease, that only chemotherapy or immuno or some kind of targeted therapies has a role, and surgery and other local therapy can't help the patient, and we can't cure these patients. This is a basic schema of oligometastatic disease. So what actually happens here is that there is a primary disease and there is a selective limited volume of metastatic nodules in the body. Why this is important, or why this is different from polymetastatic disease? So outcomes of oligometastatic treatment has greatly improved with recent medical advances, be it surgery or radiation or chemotherapies or newer kind of novel treatment modalities. The prognosis has been demonstrated to be better in these patients who have oligometastasis when we compare with polymetastasis, and it applies not only to breast but also to the other cancers like prostate and lung. I'll skip this. These are the different kind of situation how a oligometastatic disease can be found. It can be synchronous, that in the beginning only you found that a patient is a primary disease or having one or two or three separate metastatic lesions, and it could be metachronous or oligorecurrence or oligoprogression. Coming to the scenario of oligometastasis in breast cancer patient. So OMBC or oligometastatic breast cancer is a subset of metastatic breast cancer with limited number and site of metastasis. You will be surprised to know that it comprises of 20% of all MBCs. So we cannot ignore it. 20% of MBCs are oligometastatic breast cancer, and that should be thought, prognosticated and treated very differently from metastatic disease. So there is increasing evidence that prolonged disease control is possible for these patients, and it is a condition with a few metastases arising from tumors that have not yet acquired a potential for widespread dissemination. This was a very landmark study which tried to define what is limited metastatic disease or limited M1 disease, particularly for breast patients, and particularly with a threshold which is related with survival. So in any cancer modality, survival is the strongest endpoint of any study. So something which changes the survival should be a very potent kind of intervention which can be used. So what they found that they tried to evaluate what is the definition of limited M1 disease. They found that limited M1 disease in breast is defined as less than 5 metastatic lesions. This is a relevant favorable prognostic factor for these patients. This helps in selecting patients for more aggressive systemic and loco-regional treatments. Different then research started and different thought came that whether oligometastatic breast cancer, there is a shift from palliative to potentially curative treatment. So these kind of papers started coming into the picture. Long data of different institutes started generating and coming out. So this is a very long 30-year experience of a Japanese group of treatment of oligometastatic breast disease. And they found that along with systemic therapy, with selective patient, if we include local therapy like surgery or radiation, they found there lies a distinct subgroup with long-term prognosis, which is superior to metastatic breast cancer with reasonable probability for clinical cure. So long series are there, long researches, long data collection and analysis are there to support this new theory. How do we treat oligometastatic breast cancer? So chemotherapy, we all know systemic therapy is still going to be the mainstay. Surgery, I'm not covering here, but surgery for the breast, as well as in some select situation, the removal of metastatic lesion can also be option. What a little bit I'm going to talk here about is SRS or SBRT. There are other modalities also, RFA, TACE, TARE. Coming to radiotherapy and oligometastasis. So we know that there is a growing evidence of metastatic directed radiotherapy. So in 1995, this concept started. Initial 5-10 years, nothing happened. But in last decade, we can see that lots of research and publication are coming into the role of ablating those limited metastatic lesion by the use of high dose radiotherapy. In 1995, when that coin was termed, the same time, American Association of Physicists in Medicine in their task group published something about stereotactic radiosurgery, the same time when the oligometastasis was coined. What is SBRT? It is stereotactic body radiotherapy, a short course of highly focused, extremely high dose radiotherapy. So the accuracy is of the tone of sub-millimeter and the doses are almost 5 to 10 times higher than the routine radiation doses given in single or 2 or 3 sittings, and with an object of ablating that particular lesion. There was one randomized study which opened up the horizon for this therapy, and it was done for solitary brain metastasis. Following the success of SRS, SABR or SBRT, which is the treatment for extracranial lesion, has been started. You can see that it has found its place even into the NCCN guidelines, and we can see that SRS is now the preferred modality given by NCCN for newly diagnosed or stable systemic disease breast brain metastasis of any primary origin. So there was definitely a paradigm shift where it found the place in standard guidelines as a preferred method. There were some studies which came that whether can we attempt curative kind of treatment for oligometastatic lesions. And one of the things which I wanted to highlight here is that patient with breast cancer fared significantly better when we talked about a common group of oligometastatic disease. When we see about oligometastasis and CA breast and SRS SBRT, narrowing down to the current topic, this is very interesting. So oligometastatic breast cancer treated with hypofractionated stereotactic radiotherapy, some patients survive longer than a decade. So this is an eye-opener. We thought that metastatic patients have a median survival of 1 or 2 years. Those should be only given on chemotherapy and best supportive care, but no. There is a select patient class which can survive for a decade if there are true oligometastasis there. This was a very recent publication 2 years back in radiotherapy and oncology. The highlights were some breast cancer patients survive more than 10 years after oligometastatic directed hypofractionated stereotactic radiotherapy. The tumor burden, that is the lesion, volume of lesion and number, is an important risk factor. The 5-year and 10-year overall survival rates with HSRT were in the tone of 83% and 75% for bone-only oligometastatic disease. So can you see that we are talking about 10 and 5-year overall survival, that too in the tone of 70 to 80%. But unfortunately, the visceral metastatic patient like brain and liver doesn't do that well. So some patient with breast cancer oligometastatic treated with HSRT can survive for more than 10 years. Again, a thought-provoking research, does radiotherapy have curative potential in metastatic patient? The concept of local therapy in oligometastatic breast cancer. Multiple data are there treating to brain, specifically in metastasis coming from breast. So there is improving overall survival in breast cancer patient with brain metastasis which are treated with SRS. Factors which influence survival post SRS are receptor status, systemic disease control, and volume of metastasis. Overall survival was with SRS was 15.7 months. For the sake of knowledge of house, I will tell that without SRS, this was used to be 9 to 10 months. So there is an absolute improvement of 4 months in the overall survival. That is almost 30% improvement in overall survival if we include this modality. This was blanket for the entire group. But if we choose ER and HER2 positive patient, this survival was 21.4 months for this particular subset of group, which is double of the conventionally thought median survival of brain metastasis patient. Same is happening with the bone related disease. So here the survival is in the range of 60 to 83%. We are talking about bone only oligometastatic patients from breast origin. These are multiple different series which studied the tone of local control when we employ these kind of techniques. So the important thing here is that the local control at 5-year ranges from 80 to 100%. So that is pretty good. If we see survival in some of the series, 5-year survival reached up to 83%. So 5-year survival, 83% for a so-called metastatic disease, this is encouraging. Then the data is for liver, lung also. Multiple studies are there which has placed SBRT into the treatment of lung metastases, liver metastases. Lastly, I'll discuss 2-3 patients which we have done in Jaipur only in collaboration with the Sita Devi Hospital. I have taken the data and follow from Dr. Uttam. So this is the case one, 36-year-old female, CA breast left, IDC, ERPR positive, HER2 negative. In 2016, she received neoadjuvant chemo followed by MRM. The histopath was IDC, YPT1C, N1. She also received locoregional radiation to the chest wall. In 19, she got 5 lesions in liver. She received SBRT in June 19. So after 3 years, there was a progression in liver and it was treated with SBRT. Patient was on fulvestrant and palbociclib. In 2020, again, she got a solitary lesion at C2 vertebra. She again received SBRT in September 20 follow-up. She's free of disease and is still follow-up with Dr. Uttam. I can show an image that this C2 solitary lesion pre-therapy and post-therapy, you can see the PET scan that this uptake seen in the upper slide is gone into the follow-up PET CT scans. Another case, 53-year-old female patient, KPS 90, breast right, IDC, ERPR positive, HER2 negative. This was synchronous oligometastatic. At the diagnosis only, she had a breast lesion with 3 bone-only lesion. And the PET was suggestive of lesion in right breast. There are 3 bony lesions, right acetabulum, left sternal, and left occipital, calvarial, that is skull-based, skull bone lesion. She was started with the systemic therapy. We have done, as we decided, discussed that what should we do with this patient, whether we try to have a radical intent and go with the local therapies also. So she received SBRT to these 3 lesions. We get a follow-up PET CT scan done, which again is suggestive of the images are there. This is the right acetabular lesion. We can see in the upper image, the lesion is there, and post-ablation, post-SBRT, the other image is showing that there is now no FDG uptake in this area, only sclerosis is there. Likewise, this tunnel lesion in the upper and in the lower segment, that FDG avidity is gone, the lesion is now ablated. This is the third, that calvarial lesion, which is now post-treatment, it is also showing sclerotic changes with no disease activity in this. This patient later on was planned for the conventional radical approach with the treatment of breast locally with surgery, and we followed the standard protocol, and that patient fell into that category of curative treatment. Lastly is a patient, 46-year-old female, CA breast, IDC, ERPR negative, HER2 positive, underwent MRM in 14 with chemo. In 17, she had bilateral lung metastasis. She was fortunate enough to get a good response on chemo. There was a resolution of metastasis. In 19, she developed 2 solitary brain metastases treated with SRS, and the follow-up MRI was showing total ablation of those brain lesions. So 14 to the patient in 22, a metastatic patient having bone as well as visceral mets in lung and brain also doing well. So this was something new which Dr. Uttam thought, and I thank you all to giving us this platform to say that there is still a hope for some selective, carefully chosen oligometastatic breast cancers. Thank you.
Thank you, Dr. Manish, for introducing us to those interesting concepts of SBRT in oligometastatic breast disease. It has definitely added to our knowledge. Next speaker is Dr. Bhagwat Mathur. He is currently working in St. Andrew's Hospital in Chelmsford and doing a staggering number of breast reconstructions per year. He is a SMS Medical College pass out. His home is in Jaipur, but his heart is with us. He's very interested in teaching, and I must say his presentations are a treat to watch. Dr. Bhagwat, please enlighten us on your method of wise pattern breast reduction.
एक्सेस देने के लिए चाहिए जो मुझे पता नहीं है यार पासवर्ड क्या है लैपटॉप का पासवर्ड
Hello, Namaskar, good morning. It's always a pleasure to be in Jaipur and to be in front of the Jaipur Plastic Surgery audience. I will extend my thanks to the RAPS organizing committee, Dr. Pradeep Goyal, Rakesh, Sunil. I think this is probably the first meeting after the COVID. ISER was probably the inaugural meeting, and then RAPS has taken this initiative. So congratulations. Breast reduction, again, if you want to do breast surgery, then this is probably a prime operation. And all of us should have some basic concepts of breast reduction. I'm going to talk about the wise pattern breast reduction, and I think there are subsequent speakers.
Very elaborate presentation, sir. Thank you so much. You have cleared so many of my doubts. Only one thing I wanted to ask. When do you plan for internal bra support? In all the cases or?
Why not? Why not? So people now they are using MASH and all those things to give the internal bra and the support. So if you can do it, do it. In every case.
So one more question. How do you close the nip? If you are doing in inferior pedicle, how do you close nipple areola at the its position? I mean, in how many layers or?
Just 2 layers. As I say, I put 8 sutures.
Yeah.
8 stitches first and then subcuticle.
Okay. You don't lose breast tissues inside.
No, just subcuticle.
Thank you, sir.
Thank you, sir, for as I said, treat of a presentation that we just had from Dr. Bhagwat Mathur. Next speaker is Dr. Sandeep Sharma. He needs no introduction. He's the immediate past president of IAPS. He has recently organized a resounding successful conference in Goa. And sir, can I please invite you to give your talk on vertical breast reduction, your method of doing it?
Right. Good morning, everybody. At the outset, thank you, Dr. Pradeep Goyal. Thank you, Dr. Varsha, for inviting me here. It's been a pleasure. Yes, a bit tired after the organizing the conference, but nice people inviting you nicely is always a nice outcome. Sahi baat hai, sir. Yeah, and I had the pleasure of staying at the best 5-star in Jaipur. I stayed with Dr. Pradeep.
Can I invite Dr. Pradeep Goyal? So please felicitate our presenter, Dr. Uttam Soni, for a wonderful presentation and that pep talk he gave us. Dr. Manish, could you please come ahead? Are we giving Dr. Uttam's memento also? So please receive another memento on behalf of Dr. Uttam. Dr. Rakesh? This is for Dr. Uttam. So we have a short tea break now. 10 minutes tea break by the watch. Reserve your seats and come back. 10 minutes. The time starts now.
सारे delegates, please, can you guys move a bit forward? सब सोफा वगैरह के पीछे आ जाइए. फोटो कौन लेगा? नहीं.
Our next lecture is on breast reduction, how to manage complications by Dr. Sandeep Sharma, sir. Breast reduction, how to manage.
We are very thankful to IAPS for endorsing our event. Last A-Surge in Goa, we enjoyed a lot. These photographs can depict to that. That was a great event. Dr. Sandeep sir was the president for it, and Dr. Rajat was the secretary. So we all want you to join for next A-Surge 2023 at Lonavala. Thank you so much, IAPS. They didn't give us time to think only. With morning sports activities, full day of educational sessions, and evening dance and party. That's what. Yeah, the ramp walks, the dances, cultural evening. Yes, we enjoyed a lot. Over to Dr. Sandeep Sharma. There's a yes, while participating in sports event, 2 of our starts won. Dr. Pradeep Goyal sir, he won marathon. So I would request Dr. Sandeep Sharma sir to give him a memento.
Like him are there, and we should take inspiration for the jolly young man, which I always see for so many years. And रात को 12-1 बजे होते थे, सुबह 6 बजे, and he was awake in all seconds. So please
There were few categories in that marathon. Actually, there were 3 categories: less than 45, 45 to 55, and more than 55. Sir, we have probably won this trophy in less than 45 category.
And Dr. Triveni, she won the triathlon.
Triveni again. She was in under 25 category, I believe.
She is not here. There's some problem at her house, but I'll give the trophy to her, sir.
And just to add on what Dr. Varsha just said, sir, many thanks from all of us for visiting us, first of all, and giving us that IAPS, that A-Search 2020. It was one of the most grand kind of, I would say, academic as well as social celebration amongst the fraternity which we had. Thank you so much, sir.
And I would request most of you who are interested in aesthetic surgery can join IAPS and take advantages of aesthetic Pathshala. They are occurring very regularly. Every Sunday we have an article to read and a quiz that's going on very regularly. And it's very interesting.
Yeah, correct. There is actually a section for IAPS membership for trainees also. You actually pay a membership, and that membership fees goes towards your, official membership once you qualify. So basically, there's no two fee structure. You pay only fees once, and that makes you members for life. So it is a good idea for PGs also to become members of IAPS now.
And I want a big round of applause for Dr. Sunil Arora. He is now an executive committee member of IAPS. And the next party is from his side. That will be happening in very near future.
That's for sure. But all credit goes to Team RAPS actually. So I'm thankful to Team RAPS for all the support you guys have given me over the last 4 years. Thank you so much, guys. Thank you.
Yeah, and I'll just continue on that because I've got to leave in an hour's time. I'll go a bit fast because I know we are behind schedule, but any questions, please do stop and ask. This is actually supposed to be an interactive session. Okay, so again, as I said, I find this is one of the more challenging surgeries that we do. Now, why I show this photo is that I have my own center and I do all my cosmetic surgeries here. Budding plastic surgeons and young plastic surgeons, I feel that all aesthetic surgery, as far as possible, please do it at one setup only, because aesthetic surgery is not only the technical part. There's a lot of psychological, structural things which you have to do before and after. And if you are going to be using all your mind to organize that for every case, then you're going to be very fatigued surgeons. So all things which are non-surgical should be seamlessly managed by your standards in one setup. So be it a small setup, does not matter. Just do it up tastefully. Doesn't mean expensively. Do it up hygienically, aesthetically, tastefully, and try and do as much as possible in that. Only then you will build up your brand, because for aesthetic surgery, patients come to the doctor only. They don't come to a hospital. So, and if you do that, you are going to get incremental, just like the FD, you're going to get, recurring interest on your investment. So this is something which you should all be aspiring for. Most aesthetic surgery patients do not like to come to institutes. You may get them, but then you just realize that is only the 20% of the total pool that is coming. So if still you're getting a lot of patients in bigger hospitals, that means so many more are there who are not coming to you. So there's a bigger potential to tap. So that is something which you should be doing. You will cut down your complication rate much more if you are doing with one team only at one setup only. And from the beginning of your career, you should make it a point to push that मैं यहीं पे available हूँ. People will not send, may not send, because everybody has their own agenda, right? So we should also have our own agenda. Thing is that we try to cater to everybody's agenda and never make our own agenda. And our agenda becomes to adjust to everybody's agenda. That is not the way how we want to lead life. If we want to believe that we are the best in the gene pool, we are the brightest, we are the most skilled, then we should also have our own platform where we share. And if we don't have a platform, we can never display our skills. Then we call, so there are a lot of things we can discuss on that, but suffice to say, young guys, try and have your own brand. If you're going to be doing aesthetic surgery, try and be at one place only. Try and hire a nurse, hire a receptionist. It will cost you a bit in the beginning, but then anything, even if you take a flat, take a place, you're going to pay rental. So have a staff who you pay. Wherever you are, they should be there. They should be working, talking for you. The minute I have to tell the same thing to a patient, a hair transplant surgeon, he will tell patients, counseling, and very soon he'll make a presentation so that he doesn't have to speak again. Same way, you have your own staff who do all that counseling for you. That is going to reduce significantly your, complication rate and also make your life much more easier, and you can get better results. So again, we talked about this. How do we get there? Again, breast reduction techniques have evolved over time. And there are many anatomically sound techniques. And whenever there are many techniques available, that means that there is no one technique which is ideal. So every technique has its upside and everything has its downsides. Now, the first thing we talk about is what should our goal be? So again, the goal has to be a slightly mature and pendulous breast. And it should be in proportion to the patient's body size. So that itself means that one set of markings will not work. So the markings have to be dynamic, that they change based upon the patient we have at hand. So, and again, this is a reason for biggest frustration, because one person promises too much. And the younger you are, the less experienced you are, the more you tend to promise. And the older you get, the less and less you promise, because you know that that is not deliverable. So if whatever is not deliverable and you promise, you're only adding stress to yourself, because you're waiting that patients are kuch kahe bina nikal jaye mujhe. And that often does not happen. So please do not promise things which are not possible. Now, again, the challenge is to look upon the breast as a 3D concept. So that's why when you go through the markings very slowly, you write down the markings so that you are imprinting in your mind a 3D concept of the breast, which is the cover and the content. So now, again, as I said, most complications, and I'm taking simple things like infection and all out of the equation, because I believe that all these have to be done in good setups, in sterile setups, and you are not cutting any corners. So doing it the right way, there is the two things which you have to deal with: vascularity and artistry. So mastery is an understanding and accepting and conveying what is deliverable and what is not. So something which is imperfect but explained properly is also mastery. Right, so that is what way we leads to. Okay, and as with everything, practice makes it perfect. So no point in having too many discussions, too many lectures. Till you don't do it, you are not going to get good at it. So again, now, so there are three phases. The newcomer. So newcomer has to choose a technique from from the bouquet of options that you have. Then the next level, once you have learn to do a technique, you want to start minimizing your complications, avoid your complications. And then once you're done enough, then you've got to look at qualitative improvement as to how you're going to get improved outcomes. So there are always three steps that you hang ho gaya hai. Now, move. Okay. So again, how do you decide the technique based on, we have discussed this before, so we'll move faster on that. So mild, moderate, major or gigantic reductions based upon the size, what we do. As I said, in my case, I hardly ever get any mild reductions. It's sort of moderate reductions are a few, and most of them are major reductions, and increasing number as I'm doing more and more are also gigantic reductions. And none of them do I do a free nipple graft. Now, these are the fundamental concepts which we have already talked about. ठीक है बेटा. Sorry, I was looking here and I thought you also seeing the same thing. Right now, I think we'll not discuss about the options. So what has evolved? As we have evolved, is we have gone on to make shorter scars and also to eliminational scars. So those are things which we look to the future. These are the complications which we have tried to reduce. Is the tendency to bottoming out. Bottoming out means basically that the lower part of the breast is heavier and the upper part appears empty. Right, so you want it rounded and projectile. So there is a steep learning curve. Now, you got to follow certain guidelines if you want to minimize complications. So number one is doing good anatomical measurements, which we have discussed about. Check about the smoking history. We feel that in our culture, women don't smoke, but you'll be surprised as to how many do. So it is very important to ask that question. I've had problems when I've, out of respect, not asked, and I realized later on that that was the case. So that is very important to see. So now again, we talked about inferior pedicle, why I use it, how I learned it, and I've done the superior pedicle, and now I've learned the medial pedicle from Hall Findlay, and now I moved on to the supromedial pedicle. So again, which is best? This is what we want to get. This we talked about. The inferior supromedial pedicle, I can use it in all shapes, all sizes. The inferior pedicle again also can be used in different sizes. So these are all inferior pedicle. So for small to moderate, I use a vertical scar. For moderate to large reductions, I use an inverted T scar. For small reductions, I'll do a superior pedicle. For moderate to large, I'll do a supromedial pedicle, and for gigantomastia or very large breast, I'll do the inferior pedicle. So now, to me, an error is declared by compromised vascularity and its attendant cascade of complications. And a second error is a compromised breast aesthetics. That means it's not a natural looking breast. So these are the two issues which you have to deal with. Now, how do you address these problems at its inception? So the patient factors, surgeon factors, and infrastructure factors are what we have to comprehend and plan for ahead. Of the patient factors, again, more problems with a high BMI, more problems when you've got a higher mass of resection, obviously smoking, comorbidity, a very common amount, which is a thyroid issue. So hypothyroid patients are again a problem, which we have to be careful about, and a keloid tendency. Surgeon factors, again, the experience of the surgeon is important to give a good outcome. The surgical plan has to be foolproof, and you got to be sticking to the plan and the execution. Durations of surgery has a bearing. So quite often we find that people tend to do two surgeons, one on each side. Again, that helps with reducing the duration surgery, but often it comes with its own set of problems. So to me, that again is not a very good option. So you just have to be a faster surgeon. Then the infrastructure factors. Anesthesia, very important. You've got to have a cool, calm anesthetist who will keep the intraoperative blood pressure fine. Otherwise, you are dealing with a large breast with very big vessels, and they tend to open up and cause problems post-operatively. Again, this point, hygiene and sterility should be a given. They should not be a problem. In today's day, you cannot really excuse yourself for having infections because of hygiene and sterility, and that's why I insist that it's best to have our own setup where you don't cut corners. And again, post-operative monitoring and knowledge nursing, again, that's only possible if there is a good understanding between you and your team of nurses who know what you're looking for, and they sort of do that for you. And now, complications can be major or minor, and they can be surgical or aesthetic complications. So now when you look at articles, and there are enough articles talking about risk factors and complications in breast surgery. And if you look at the percentages, you'll be surprised at to the number of, like here you see wound issues, minor wound issues in 26% of patients, right? Major issue in 1.5% of patients. So again, if these are sort of in high volume centers where they are very experienced. So lesser experience, you can almost sort of, make it 1.5 or 2 times what it is talked about. So when we dwell on each issue of this, again, here Western study, so infection rate is lesser, and that's what we should be aiming at as well. Fat necrosis, again, it is a small issue, but to me, fat necrosis again does with one is vascularity, and second is tissue handling. A heavy tissue handling of the breast does tend to lead to higher fat necrosis in the long
So what's another? So what's the treatment for erected nipples? For erected nipples, some people, prominent, no, not prominent. In males, what they say when they do exercises and everything, due to rubbing of the inner vest and everything, the nipple gets erected, and they usually come for these corrections. So, what's your take for that?
The good thing is I don't get those kind of things.
They are very conscious of
They are very conscious. It's a very frequent problem.
the nipple reduction. I think that's a
So denervation usually get recurrence. So what do we usually do? We just denervate and put some fat below it, but still we get some recurrences there. Yeah. We just do substitutes.
What have you done?
Sir, we usually do substitution kind of things, and then they invariably come back. So we have tried to put some fat below after substitution, so that the nerves don't regenerate again. But still, some people come back.
Yeah, I've had people come, not people, two people have come, but the thought of surgery has put them off and they didn't come back again. So, I mean, I just said first was obviously, like just accept it because it's physiological. And they said, t-shirts mein nahi chalta hai. And also then I said, okay, only thing I can think of is a wedge resection of your nipple and, reducing the projection, and they did not come back for that.
Pardon?
Botox kya hai?
Botox, they usually come back. It's not a permanent solution for that.
But does it work?
Botox, I don't.
I mean, it could be worth trying. That's not a bad idea.
I have not tried it.
See, the thing is, whether it works in the long term or not should not be our decision. Whether they want to, if it's a simple injection and they can come back every 3-4 months and 6 months and get it done, it may be fine. See, because that problem may go away after a period of time when as the person matures, may not have the same sort of stimulation. Yeah.
So the problem is that
No, it's not a cycle, it's a real problem. I mean, I've got enough people who say when they wear tight vests and it is seen and they don't like it.
Botox, we have to always explain that this thing can come back.
Yeah, but that is fine. See, explaining is not a problem. Tell them, let's try this. If it works, we can think of something else. So that's not a bad idea to see.
Any experience regarding any other techniques?
No, I'll get to you. I'll ask around. I have a few groups where I'll put it on, and then I can, I'll take your number here.
फैट डाला तो फैट से तो काफी सब्सटेंस करके फैट डाला हमारा फैट नैनो फैट kind of thing just for the space
rather than waiting by everyone's consensus, let us start with let me invite Dr. Pradeep Goyal sir for his lecture on nipple areolar reconstruction. सर को कुछ इंट्रोडक्शन का जरूरत ही नहीं है, बट ही इज एक्स प्रेसिडेंट रैप्स नाउ एंड प्रेसिडेंट ब्रासा, and he's such a young and joyful person to see. Every time you feel that at his age I should be like that. That's the aim.
Thank you, Reps, and the team for inviting me to this podium. I have a small presentation on neck reconstruction. It it's supposed to be at the end of all the sessions, but because you had learned the technique of reduction, of course, the neck reconstruction comes after the reconstruction of the breast, but still we won't cover that topic, the reconstruction of the breast. But I'm just going to cover the neck reconstruction. I welcome you all to the Pink City. This is the beautiful gate by Patrika at Jawahar Circle. Ideally, the nipple is located at the point of maximum projection on the breast mount. If we measure the external notch to nipple distance is around 90 to 21 centimeter, and the nipple to inframammary fold it is 7 to 8 centimeter. The other dimensions for the nipples is diameter, it is 1.3 centimeters, height is 0.9, and the nipple areola ratio is 1:3. The areola is around 4 or 4.5 centimeter in diameter. So we'll be discussing the reconstruction of nipple areola complex after breast reconstructions. What are the prerequisites for neck reconstructions? So the breast reconstruction should be stable. The breast symmetry should have been achieved. And usually the timings for neck reconstruction 3 to 5 months after the revisional reconstructive surgery. Now the goals of neck reconstruction is the position, symmetry, color, size, projection, and the sensitivity. Now we have various options for neck reconstructions, like non-surgicals, surgicals, and the areola reconstruction. We will be discussing under 3 headings. I think I have to stop here because our chief guest is on the way. He is entering. Let's welcome our chief guest, Dr. Sudhir Bhandari, the Vice Chancellor of Rajasthan University of Health Sciences. We welcome you, sir.
Good surgeons not only concentrate on their technical abilities, but also on their appropriateness of what they are doing. With this theme, to excel, I welcome you all today for the Breast Update 2022 at Eternal Hospital. As a plastic surgeon, whether as an individual or as an association, we strive to push our boundaries and give each and every patient of ours a maximum normalcy and a good self-esteem. With such vigor and enthusiasm, I once again welcome you all to this deliberation of knowledge, ideas, and inspiration. And from all our perfectionist breast plastic surgeons across India and UK. Now I welcome Dr. Sudhir Bhandari sir, Dr. Kalra sir, Dr. Rakesh Jain sir, Dr. Malti ma'am, Dr. Bhagat Mathur sir, and Dr. Manmeet Pakkar ma'am to the dais for lamp lighting and inauguration. नहीं चला तुषारहार धवला या शुभ्रवस्त्रा
वस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती सरस्वती भगवती
Thank you, sir. Please take your seats. Now I request Dr. 𝐺𝐠𝐬𝐿, sir, to please welcome our chief guest, Dr. Sudhir Bhandari, sir. Dr. Manmeet Makkar, madam, to please welcome the senior most plastic surgeon of Rajasthan, Dr. Malti Gupta, ma'am. Dr. Rakesh Jain, sir, to please welcome our very dear faculty, Dr. Bhagwat Mathur, sir. Now I request Dr. Pradeep Goyal, sir, to please welcome Dr. Sandeep Sharma, sir. Dr. Sunil Arora, to please welcome Dr. Sandeep Jain, sir. I request Dr. Rakesh Jain, sir, President, Rajasthan Association of Plastic Surgeons, to please welcome our take over from here.
Good afternoon, everybody, and respected dignitaries on the dais, our dynamic principal and Vice Chancellor now of Rajasthan University of Health Sciences, Dr. Bhandari, sir. I'm deliberately using this word dynamic because it's synonymous with Dr. Bhandari, sir. If you'll see, if you have met Dr. Bhandari, sir, then you'll find he's really dynamic. And the dynamic word, what is dynamic? Dynamism is there that you can find in the Bhandari, sir. And Madam Malti Gupta, ma'am, former HOD Department of Plastic Surgery, and she's teacher. We are all students of ma'am. She's the senior most plastic surgeon in Jaipur. Even today, the name of the department is by Madam Malti Gupta. Everywhere we go, Malti Gupta madam ke means it is like this. Dr. Bhagwat Mathur, sir, who is presently working at the St. Andrews Center for Burn and Plastic Surgery, UK. He is the first MCH, I think, sir, first MCH from Jaipur. He is from the first batch, second batch. He is from second batch. Ma'am is there. Dr. Bhagwat Mathur was a student of ma'am. Dr. Kalra, sir, former head of department, present head of department, Plastic Surgery, SMS Hospital, Jaipur. And Dr. Manmeet Kakkad, Vice President, Medical Affairs, ESCC, and all the guest speakers and dear friends. Dr. Varsha has told me to give brief introduction of Dr. Sudhir Bhandari, which is, I think, it is just not possible. We have to organize one conference for that because it is so big that we just can't, I just can't read even within 2 minutes. So those who are from SMS, they know Bhandari sir very well. But those who are alumni from SMS and outside, they can very well appreciate the reconstruction, the facelift which has happened in the SMS hospital. You can, if you'll visit the hospital, then you'll feel really what reconstruction and what construction and what facelift has done by Dr. Bhandari sir. This will not last only for 5 to 10 years. This will be for next 50 to 100 years. So on behalf of Rajasthan Association of Plastic Surgeons, I welcome you all. This is the first CME by a newly elected body of Rajasthan Association of Plastic Surgeons. I would like to stress upon that awareness of aesthetic and reconstructive breast surgery is increasing. However, the pace is slow, and it is partly due to the unavailability of the avenues for the patients to reach out, which is why we wanted to organize this workshop for all of you to enhance your skills and confidence in treating patients. 2 days back, while preparing for this CME, I had an opportunity to talk with Dr. Bhagwat Mathur sir, where I jokingly mentioned that why don't you come back to India? Why don't you return to India? He responded like this, "Kya kare yaar, yahan aakar itna kaam hi nahi hai." And he's right. He's partially right also. This is partially true because breast cancer survivors tend to undergo reconstructive surgery less often. And the occurrence of breast cancer in India stands 1 in 28 women in their lifetime. But according to another survey, this is vastly underreported. It is more for urban and rural, more for urban than rural women. Kerala is having highest of this. And it is common in younger age group, that is almost 50% of all the cases are in the age group of 25 to 50. And 70% of the patient present in advanced stage. As it stands today, breast cancer is the #1 cancer among Indian women and the second most common cancer, only surpassed by the cervical cancer. With a considerable survival rate, women in India needs a way back to feel complete again, and we are at the forefront of realizing their dream. If we talk of the aesthetic surgery, India ranked 4th in the world, where people are going for surgical and non-surgical plastic surgery procedures, but it is because it is cheapest in India. If we go to some statistics, I will tell you some statistics. As we are from morning, we are just talking of the breast reduction, breast augmentation. So I'm just giving you the statistics, what is there in the world. Breast augmentation worldwide, it is 16 lakhs cases. In the US, it is 1,93,000, and India, it is only 27,648 in 2020, which is decreased by 24% from 2019 because of the COVID. Breast reduction worldwide, if we talk of worldwide, then it is 4,26,000. In the US, it is 7,320, and in India, it is only 16,320. And breast reconstruction, the data is not available. It is only the US that is the data is there. That is 1,37,808. I have heard from my peers and the juniors many times that other fields are taking over share of medical practices. It is a common thing, but this is a field that belongs to us exclusively. So it is my hope that each of you make the most of your time here by learning from those who are the best in this field and prepare themselves to contribute. Thank you very much and best wishes. Thank you.
Is Dr. Manmeet Makkar ma'am to speak few words.
Thanks, Dr. Varsha. On behalf of Eternal Hospital, I welcome Dr. Sudhir Bhandari sir, Dr. Bhagat Kumar sir, Dr. Kalra sir, Dr. Malti Gupta ma'am, Dr. Sandeep Sharma sir, Dr. Sandeep Jain, and our dearest Dr. Pradeep Goel sir, Dr. Sunil Arora, and the other delegates who are present here. So, heartfelt congratulations, Dr. Varsha, for organizing such a wonderful, MADEX on topic breast augmentation and breast update. So, I'm sure you are having very interesting and, enthusiastic topics. So, good luck. Thank you.
Thank you very much, ma'am. Dr. Sudhir Bhandari has to leave early, so I request Dr. Sudhir Bhandari sir to speak few words and enlighten us here. There is going to be a display of what he is going to build, 22-story building he is going to build for as a suite class building for patients for government sector. And one more thing I would like to add, as he said, about your dynamism, there is one more thing, that you are very much available to everyone. There's a small episode, pediatric surgeons came to you for their OT thing, and you just in a one go, you told them, yes, take this money, go and build your OT and start functioning.
Respected Dr. Malti Gupta, Dr. Kalra, Dr. Pradeep, who is not there, Dr. R.K. Jain, it's been wonderful to be here. I'm humbled and honored for having been invited. My apologies for being late. My apologies for making the change in your sequence of presentations, because there are some unavoidable things happen in medical profession. So I thank you very much for having invited me. It's been wonderful. The reason I had to come, even if late, because I'm an admirer of our plastic surgery department. So the work they have been doing, they are phenomenal good work we do. Doctors always get late. I happened to be in US 2 years before, pre-COVID. And one weekend, my colleague who took me to the church where they'll make a circle, and in front of Father, you have to confess that whatever wrong, bad things, or whatever troubles you or pains you, you confess with Father so that you feel lighter and you feel happy. When my turn came, I said, look, I belong to a profession where 95% time I'm not able to meet my appointment, and 5% time I meet that too by accident. So that was my pain and discomfort, which happened today also. So my apologies. I think reconstructive breast surgery especially is a wonderful thing. Cosmetology has changed totally the outcome of breast cancer. I'm very close. Dr. Bhagwat Mathur is my senior, very respectful senior, very talented one. I'm an admirer of his work. I really want to involve and absorb him somewhere in Rajasthan, in Jaipur, we can do. If you look at this, what Dr. R.K. has said, the rising incidence of breast cancer, the irony of fate is that in our country, 50% report in stage 3 and 4, almost 10 to 15% almost in stage 4. American Oncology Criteria, Conference Criteria, in recently present data, they shared that there a woman with breast cancer would survive for 5 years or more, almost more than 75%, while this figure is very low in our country. And that's the reason there's a great scope of reconstruction, what we do the augmentation, or whatever you want to rehabilitate the lady. So the pain, discomfort of breast issues can be diluted to a great extent by a wonderful amalgamation of plastic and the cosmetic surgery. All of you have gathered to discuss the best of techniques and methodology. I compliment, and probably cosmetology looks to be one of the finest component of the plastic surgery. I day in and day out see the results of my institute. I belong to an institute where our daily OPD is 10 to 15,000 and annual OPD is around 40 lakh. So naturally the volume of patients we have, which includes all the people with breast issues, and they are eligible for the breast surgery. But yes, what Dr. Bhagwat observed, that we need to build up the eligible people, we need to motivate people, we need to work in this direction. But I'm extremely proud of our plastic surgery department, the volume they act upon, the number of cases they do, which is phenomenal. And in fact, the plastic surgery is a very interesting branch. In fact, I must share with you, there's a saying that you cannot buy happiness with money. You cannot buy happiness with money, but through plastic surgeon you can buy, because he just remodels you. And I was seeing a very interesting interview. It is a true thing. I was seeing a very interesting interview of a Hollywood actress. In that interview, she was asked, what do you miss most? You have achieved everything in life. And she said, I miss most is people chasing me, men running after me, men looking at me, men craving to meet me. I miss that most. The spontaneous someone in audience replied, contact a plastic surgeon to regain it back. So that's the way beauty of plastic surgeon enjoys. That's, I thought, take an opportunity, because I'm having multiple meetings this day, because we are having inauguration of our project, and we are having foundation laying stone. This is going to be a 22-floor tower in SMS with a helipad facility. And those who are alumni of SMS, I thought they will be happy to see, and it will interest them what is going to be there. And people from Eternal, I can only say, ma'am, we are trying to match you. So that's one thing. I compliment and congratulate all of you for this wonderful CME. My apologies for breaking the queue of talking to you people, because I got some ongoing commitments. So thank you very much for having invited. Thank you, Dr.
Just a second, sir. I request Dr. R.K. Jain, sir, to a token of thanks from Rajasthan Association of Plastic Surgeons. Thank you very much, sir.
We wish you had it. I would have loved it. I'd ask them to make my shares. Continuing our session, I request Dr. Malati Gupta ma'am to enlighten us with her experience.
We have
हेलो, नमस्कार। नमस्कार तो बोल दो भाई। मुझे पता है सबको भूख लग रही है शायद। हाँ या ना? तो मैं थोड़ा सा शेयर करना चाहूंगी। कालरा साहब, आपका अटेंशन मैं चाहती हूँ थोड़ा सा। आपके बिना मेरी स्पीच होगी नहीं। आई थिंक सबसे पहले तो मैं कॉन्ग्रेचुलेट करना चाहूंगी रेप्स को, और मेरे को बहुत खुशी है कि इटर्नल हॉस्पिटल में ये हो रहा है, क्योंकि इटर्नल हॉस्पिटल के जो संस्थापक हैं समीन शर्मा, डॉक्टर समीन शर्मा, वो हमारे स्टूडेंट रहे और शायद हिस्ट्री में मेरे ख्याल से वो ही हैं जिन्होंने सारे साल हर सब्जेक्ट में गोल्ड मेडल लिया था एज ए स्टूडेंट। और फिर वो चले गए बाहर, तो हमें लगा कि अब भी बाहर क्यों जा रहे हो, यहीं रहो, लेकिन फिर आके जो इन्होंने ये शुरू किया हेल्थ की फैसिलिटी, आई थिंक दिस इज वेरी गुड फैसिलिटी, इट्स वन ऑफ द बेस्ट वी हैव इन जयपुर इन राजस्थान। तो आई एम रियली हैप्पी कि मैं यहाँ पर हूँ। और दूसरी बात ये कि राजस्थान एसोसिएशन प्लास्टिक सर्जन्स जो काम कर रही है और जो शुरुआत 4 साल हो गए मेरे ख्याल से, 4 या 5 साल शुरू हुई है, तो ये बहुत अच्छा, सुनील बैठे हैं जिन्होंने बहुत डायनामिक तरीके से इस एसोसिएशन में पार्ट लिया और इसको आगे बढ़ाया। तो आई थिंक ही इज द वन हु इज टू बी कॉम्प्लीमेंटेड फॉर दिस। एंड अब ये ऑनगोइंग है और मैं राकेश के लिए मैं आई थिंक ही इज वेरी लकी दैट ही हैज गॉट 2 वेरी ब्राइट असिस्टेंट्स, वन इज वर्षा एंड द अदर इज संगीता। तो 2 महिलाएं जब साथ होंगी तो एम्पावरमेंट 4 गुना 5 गुना 10 गुना हो सकता है। तो आई थिंक राकेश तो कुछ थैंक यू, बिकॉज आई एम अ वुमेन सेंट्रिक पर्सन। मुझे लगता है कि जितना महिलाएं आगे आती रहे, और मनमीत यहाँ बैठी है, मुझे बहुत अच्छा लग रहा है। आज मंजू जी शायद नहीं है यहाँ पर, तो कॉन्ग्रेचुलेशंस टू बोथ ऑफ यू। मैं सोचती हूँ कि मेरा सपना था राजस्थान एसोसिएशन, अखिलेश अगर यहाँ है तो नहीं है शायद, क्योंकि बहुत साल हो गए। तब अखिलेश जब लखनऊ से आए थे तो ये बात हमारे डिपार्टमेंट में हो रही थी कि हम एक एसोसिएशन ऑफ प्लास्टिक सर्जन्स ऑफ इंडिया के चैप्टर बनाएं, और अगर नहीं तो हम राजस्थान की एक अलग से बनाएं। उस वक्त तो ये नहीं पॉसिबल हुआ, लेकिन वो जो सपना मैंने देखा था वो कहीं ना कहीं वाइब्रेशंस चलते ही रहे। और अल्टीमेटली जब डॉक्टर कालरा ने ये शुरुआत की थी, संतोखबा में शुरुआत की थी, लेकिन कहीं से वो फिजल आउट हो गया। तो अब ये शुरुआत जो हुई है ये बहुत स्ट्रांग हुई है। तो क्योंकि एक बार गिर के जब उठता है इंसान तो ज्यादा स्ट्रांग हो जाता है। तो आई थिंक राजस्थान एसोसिएशन हैज अ ब्राइट फ्यूचर, एंड थैंक यू सो मच फॉर स्टार्टिंग द एकेडमिक एक्टिविटीज, बिकॉज व्हाट आई मिस इन माय लाइफ मोस्ट इज द एकेडमिक्स। तो वो हमारी जान होती है एकेडमिक्स, है ना, तो वो बहुत जरूरी होता है। और अब ये जो एकेडमिक एक्टिविटीज हो रही है, और आपने जो सब्जेक्ट लिया, आई थिंक डॉक्टर भगवत कहीं बाहर चले गए हैं शायद, तो जो ये सब्जेक्ट आपने लिया ये स्टेट ऑफ द आर्ट सब्जेक्ट है। बट व्हाट आई वांट टू नो एक्चुअली कि ये इंसिडेंस बढ़ रहा है या अवेयरनेस बढ़ रही है? अवेयरनेस की वजह से केसेस ज्यादा आ रहे हैं या इंसिडेंस ज्यादा हो रहा है? आई थिंक वी नीड टू लुक इनटू दैट। वो बहुत सिर्फ अवेयरनेस ही है या इंसिडेंस भी? आई थिंक वी नीड टू लुक एट इट साइंटिफिकली। कोई ना कोई इस चीज को स्टडी कर सकता है, क्योंकि अगर अवेयरनेस ही बड़ी होती तो अर्ली स्टेजेस में ज्यादा आ रहे हैं कि अभी भी वो 3rd और 4th स्टेजेस में आ रहे हैं कैंसर पेशेंट, ये देखने की बात है। तो अगर अवेयरनेस बड़ी है तो वो उनको जल्दी ही आना चाहिए। तो आई थिंक वी नीड टू लुक इनटू दिस। और थोड़ा सा मुझे लगता है कि रूरल एरियाज में हमको ज्यादा स्प्रेड आउट करना चाहिए अवेयरनेस प्रोग्राम्स को, ये ऐसा मैं सोचती हूँ। आज मैं ऑनलाइन सुन रही थी, एंड थैंक यू वर्षा, थैंक यू सो मच फॉर लिसनिंग टू मी। आई नो प्रदीप से तो आप कभी भी बात कर सकते हो, मेरे से कभी कभी कर सकते हो। तो आपने मेरी बात को माना और इसको हाइब्रिड किया। तो मैं सुबह आपके भाषण सुन रही थी, तो उसमें मुझे लगा कि उत्तम ने बहुत अच्छी बात बताई थी कि एक तो लीगैलिटी को अवेयरनेस होना चाहिए, और दूसरा हेल्थ के लिए कहा था उसने, और वो बहुत अच्छी बात थी, क्योंकि डॉक्टर सबसे ज्यादा पुअर होते हैं अपनी हेल्थ मेंटेन। आप वैसे डॉक्टर प्रदीप से सीख सकते हैं कि हेल्थ कैसे मेंटेन करना चाहिए, लेकिन हाँ हेल्थ बहुत इंपॉर्टेंट है। तो हम वी डोंट हैव टू रन आफ्टर मनी एंड अदर थिंग्स। एकेडमिक्स हैव देयर ओन प्लेस, लेकिन अपनी हेल्थ का हमें ज्यादा ध्यान रखना चाहिए। तो ये बातें बहुत अच्छी सी बताई थी संदीप ने, बहुत अच्छे प्रोग्राम। अब मुझे अच्छा लगता है कि यहाँ पर 2nd जनरेशन और 3rd जनरेशन प्लास्टिक सर्जन्स के बैठे हैं। हमारे खुद के डिपार्टमेंट के 1st बैच के शायद डॉक्टर अरुण यहाँ नहीं आए, पर वो जयपुर में ही हैं, और डॉक्टर भगवत 2nd बैच के हैं, और डॉक्टर प्रदीप गोयल 3rd बैच के हैं, 3rd बैच के हैं, और राकेश जैन कौन सी बैच के हैं पता नहीं। तो आई मीन ये सभी यहाँ के जो प्रोडक्ट्स हैं, और मुझे अच्छा लगता है। बस मुझे एक ही दुख जरूर होता है कि जो डिपार्टमेंट हमने बनाया था, या जिसके मैं अपने आप को कहती हूँ कि इट्स माय बेबी इन द सेंस बिकॉज आई हैव बीन एसोसिएटेड विद दैट डिपार्टमेंट सिंस डे 1। हमने उसको छोटे से उससे शुरू किया, 5 बेड की यूनिट से शुरू हुआ था, फिर 12 बेड बने, किसी और वार्ड में मिले, हमें एक वार्ड नहीं मिलता था, लेकिन वो जनरल सर्जरी के अंडर में ही रहा टिल 1985 when we were able to have a separate department of our own. And then we had 2 presidents. One was Dr. Mangal, who is currently head of the department at Sir Ganga Ram, and Arun Mathur. 2nd batch में Bhagwat and somebody else had come. he left and Bhagwat was alone. तो थर्ड बैच में ओके गुप्ता एंड प्रदीप गोयल आए थे। तो ये दोनों मेरे साथ बहुत ज्यादा काम किए थे और मुझे लगता है कि मैं काम कर पाई तो इन दोनों की मेहनत के हिसाब से विषय से ही कर पाई थी। तो ये जिस तरह से डिपार्टमेंट डेवलप हुआ तो मेरी जान वहां पे बसती ये मेरे को कहना चाहिए कि जिस लाइक यू नो द पेरेंट्स हैव, उनकी जान उनके बच्चों में होती है उसी तरह से। पर अनफॉर्चुनेटली वहां पे कभी मुझे ऑफिशियली, मैं पिछले 22 साल में एक बार भी नहीं गई हूँ ऑफिशियली, मुझे कहीं भी विजिट करने का मौका ही नहीं मिला डिपार्टमेंट को। तो मुझे थोड़ा थोड़ा तकलीफ होती क्योंकि आजकल की शायद कल्चर ही ये है कि हम माता पिता को भूल जाएं और हम बाहर भी जाके, विदेश में भी जाके बस जाएं। तो शायद ये आजकल की कल्चर का इफेक्ट होगा, मुझे नहीं पता, बट दिस इज व्हाट आई डू मिस। तो ये मैं जरूर आप सबके सामने कहना चाहती हूँ। और कुछ बातें मुझे जो पसंद आती हैं वो ये है कि आज यहाँ बहुत सारी लड़कियां हैं। तो आप सब पीजीज हो, जितनी भी लड़कियां यहाँ हैं 50%, वेरी गुड। तो मैं सपना ये देख रही हूँ कि एक दिन ऐसा आएगा कि जब राजस्थान एसोसिएशन प्लास्टिक सर्जन की प्रेसिडेंट भी महिला होगी और सेक्रेटरी भी महिला होगी और ट्रेजरर भी महिला होगी और एग्जीक्यूटिव में 50% महिलाएं होंगी। तो ये सपना मेरा जल्दी पूरा होने वाला, आई होप सो। तो ये आई कॉन्ग्रेचुलेट ऑल ऑफ यू द वुमेन हुआ, क्योंकि मैं इसलिए कह रही हूँ कि मैं पहली सर्जन थी राजस्थान की महिला सर्जन और मुझे सर्जरी में हाउस जॉब नहीं दे रहे थे, ये कहकर कि सर्जरी महिलाएं कर ही नहीं सकती, लड़कियां कर नहीं सकती, बहुत टफ होती है, फलाना ठिकाना। तो मुझे नहीं दे रहे थे। जब मैंने 1964 में अप्लाई किया तो मुझे नहीं मिल रहा था। आप लोग तो पैदा ही नहीं हुए होंगे, आप लोग तो तभी भी नहीं पैदा हुए होंगे जब मैंने MCH किया था। तो ये काफी टफ रहा मेरे लिए, लेकिन जब एक बार मिल गया तो मुझे कोई दिक्कत नहीं आई इस तरह की। पर हाँ, आपको एक फ्लैगशिप होना पड़ा, आपको एक दिखाना पड़ा, एक रास्ता दिखाना पड़ा। और उसके बाद बहुत लड़कियां सर्जरी में आई। तो उसके बाद जब MCH तो किसी ने सुना ही नहीं था, यहाँ कोई होता नहीं था, MCH नाम की क्या चीज होती है पता नहीं था। So I became the first person to do MCH in plastic surgery, even in any other subject. We didn't have any MCH doctors in Rajasthan in 1967. तो तब हम गए, मैं 73 में करके आई थी अपना MCH। उसी साइमल्टेनियसली डॉक्टर S.C. माथुर फ्रॉम यूरोलॉजी के वो वेलोर से करके आए थे। So this became a historical event, you know, and this opened up the path for many others. I remember so many people who used to come to me कि आप हमारे रोल मॉडल हो, हम आपसे सीखेंगे कि आप कहाँ गए थे, क्या करने गए थे, DM and all this करने के लिए। तो अभी have to be, you know, एक हमको रोशनी आगे दिखानी पड़ती है कि हम क्या कर रहे हैं। तो आई एम सो हैप्पी कि आज भगवत भी यहाँ हैं और सब लोग यहाँ हैं और सब साथ बैठ के काम कर रहे हैं, अपना अपना एक्सपीरियंस शेयर कर रहे हैं। आई एम लिसनिंग टू ऑल द पेपर्स और बहुत अच्छा लगता है मुझे उसमें पार्टिसिपेट करना। और मैं राजस्थान एसोसिएशन को खास तौर से कॉन्ग्रेचुलेट करके और बेस्ट विशेस देना चाहती हूँ कि आप जितना एकेडमिक्स काम करेंगे, और आज आपने शायद अवेयरनेस प्रोग्राम भी रखा, आई थिंक दैट इज वेरी वेरी एसेंशियल थिंग। तो अवेयरनेस जब तक आप नहीं करेंगे आपका आधा ही काम होता है। और दूसरा मैं कहूंगी कि ये जरूरी नहीं है कि आप सर्जरी ही करें। जैसे मैं अभी रिटायर हो गई, 22 साल हो गए, तो जरूरी नहीं है सर्जरी करें, आप बहुत कुछ कर सकते हैं। वुमेन एम्पावरमेंट के लिए बहुत कुछ कर सकते हैं और हम करते हैं। मैं ये नहीं कह रही कि मैं थ्योरी नहीं बता रही हूँ। जहां तक सुधीर भंडारी का सवाल है, सुधीर इज रियली रियली, जैसे सब कहते हैं, मैंने डॉक्टर RM कासलीवाल से लेके और अब तक के सारे प्रिंसिपल्स को फेस किया है, देखा है, उनके अंडर में काम किया है। इवन डॉक्टर SR मेहता बहुत डायनामिक थे, लेकिन फिर भी सुधीर इज रियली आउट ऑफ द बॉक्स। और जैसे जो उनकी नेचर है, जैसे सॉफ्ट स्पोकन है, जितना हेल्प करते हैं, जैसे वर्षा बता रही थी, इतनी प्रॉम्प्टली उनका हेल्प होता है। ही वॉज आउट ऑफ स्टेशन व्हेन आई कॉल्ड फॉर somebody whom I didn't know. Somebody called me, she said, बिकॉज हम NGOs के साथ हैं तो वो कोई भी फोन करके कभी भी हेल्प लेता। शी सेड कि उसका हीमोग्लोबिन 4 ग्राम है और वो बिल्कुल फेंट हो रही है। मैंने कहा एक एम्बुलेंस भेजते हैं आपको 108 का, आप आइए, SMS में जाइए। एंड आई फाउंड आउट इट सुदीप भंडारी का एडमिशन डे था। आई कॉल्ड हिम अप, ही वाज नॉट इन जयपुर, ही वाज समवेयर डाउन साउथ समवेयर। ही सेड मैडम 5 मिनट में एवरीथिंग विल बी डन, यू डोंट वरी, मेरा असिस्टेंट आपको कॉल करेगा। एंड विद इन 5 मिनट्स समबडी कॉल्ड मी, पर्सन वॉज लुक्ड आफ्टर, सब कुछ हॉस्पिटल से उसको हुआ, ब्लड ट्रांसफ्यूजन उसको 5 लगे, शी वॉज हेल एंड हार्टी व्हेन शी वेंट बैक। तो ये उसका जो आउटलुक है ये हम सब में होना चाहिए. क्या प्रॉब्लम है, सब में होना चाहिए, होता है, लेकिन हम उसको वी जस्ट डोंट ब्रिंग इट आउट. तो सुधीर इज वन ऑफ दोज आउटस्टैंडिंग पीपल, और जितना वो काम कर रहे हैं जब से वो प्रिंसिपल बने हैं, इट्स रियली अप्रिशिएटेड. तो अब सुधीर नहीं है, मैं उसके सामने नहीं कह रही, पीछे से कह रही हूँ, बिकॉज आई डोंट हैव एनीथिंग टू गेन फ्रॉम इट. तो मैं चाहती हूँ कि सब हमारे लोग उसी तरीके से काम करें और प्लास्टिक सर्जरी डिपार्टमेंट और आगे आगे बढ़ता जाए. और कभी कभी मुझे भी याद कर लेते हैं तो मुझे बहुत अच्छा लगता है. तो याद करते रहिएगा, मैं भी आपको याद करती रहूंगी, नॉट एज अ पेशेंट और अ डॉक्टर बट एज अ ह्यूमन बीइंग. एंड विश यू ऑल द बेस्ट. थैंक यू सो मच फॉर इनवाइटिंग मी.
Thank you so much, ma'am. Now I would like to request all of you to proceed with the lunch. We'll meet at 2 o'clock for half an hour.
everyone. I cannot forget the name. I can forget the names of people, but they are there in my heart. Sir, भावुक हो रही है. Yes, of course. I'm thankful to Dr. Malti Gupta, ma'am. I'm very thankful to everyone. Thank you so much. I think we'll proceed with the awareness program shortly.